or resident to take that to your program and to implement one thing from today's session. So to start our journey today, we're going to talk a little bit about antibiotic use and antimicrobial resistance and the relationship between the two. In 2019, the CDC released a report about antimicrobial resistance. And within that report, they noted that there are more than 3 million antimicrobial resistant or Clostridioides difficile infections annually, resulting in nearly 50,000 deaths when you take into account both antimicrobial resistant infections and Clostridioides difficile infections. Worldwide, a group of investigators collaborated to look at worldwide antimicrobial resistance statistics. And they noted that drug-resistant infections are associated with 4.95 million deaths and are directly attributable to 1.27 million deaths. And I think the key message here is that antimicrobial resistance can impact anyone and everyone. When these bacteria or fungal infections become resistant, it limits our ability to fight the infection with antibiotics. We do have a great concern and a growing concern that antimicrobial resistance will present challenges to modern healthcare. So a lot of the things that we take for granted, such as the ability to do joint replacement surgeries or the ability to treat patients with chemotherapy when they have cancer, these things could be at risk because of resistant organisms, because we need to prevent infections in those types of patients. And if we have resistance, it makes managing infections in those critical patient populations so much more challenging. Taking a look a little bit more deeply, both the World Health Organization in 2017 and the United States Centers for Disease Control and Prevention in 2019 published information about pathogens that are considered to be priority for antimicrobial resistance. And as you can look at this side-by-side comparison, there are a lot of similarities between the two lists, but there are some differences, and that just takes into consideration the differences that we see globally in resistance in different parts of the world. But what you can see on that top half of this graph in the areas that are mostly marked in red is that there are a lot of similarities. So leading the top of the list is tuberculosis, which is a global health risk for the World Health Organization and serious for the CDC. Candida auris, which is urgent for the CDC. Clostridioides difficile, which is urgent for the CDC. Acinetobacter baumannii, which is carbapenem resistant, which is critical and urgent for the World Health and CDC respectively. Our Enterobacterales, that's resistant to carbapenems or third generation cephalosporins, and then Pseudomonas aeruginosa, that's carbapenem resistant or multi-drug resistant. And as you work your way down the list, you see more and more organisms that have been identified as being critical. And this just shows you that global threat that these organisms demonstrate to our healthcare systems and to our patients that we take care of. And encourage you to take a look at both of these reports. They have a lot of good information about statistics surrounding the number of infections that we see with these different organisms, and also some strategies to prevent these infections. And I will just mention that the World Health Organization list is expected to be updated at some point still within this year of 2023. So how does antibiotic use play into the development of antimicrobial resistance? I think a lot of us on the call today know that unnecessary antibiotic use drives antimicrobial resistance, whether that's overuse, so prescribing too long, to overly broad antibiotics, so a broad spectrum agent when a narrow spectrum would have been sufficient. We also know that resistant organisms adapt and spread between patients within our healthcare systems and between different parts of our healthcare system. And really, I think the third point here, that there's a connection between healthcare facilities, our environment, and the food supply, is something that is becoming more and more common. And more we're taking this approach of making sure that we're thinking about all of these pieces when we think about how antibiotic use impacts antimicrobial resistance. I'm sure many of you are aware of the impact of COVID-19 on antibiotic use and resistance. Certainly, the worldwide pandemic brought about a lot of challenges to our healthcare systems and to providers taking care of patients with this infection. In the United States, the CDC published in 2022 a report regarding the impact that COVID-19 had on antibiotic use and resistance. And what they found across the United States was increases in antimicrobial use, especially during the early parts of the COVID-19 pandemic when treatment options were limited and it was difficult to differentiate bacterial from viral infections. They also recognized there were challenges with maintaining infection prevention and control recommendations, particularly when personal protective equipment was in short supply. And that led to increases in healthcare-associated and antimicrobial resistant infections. What they also noted in that report is that the COVID pandemic impacted the transfer of data to the CDC. So there's also some information that's unavailable to them from that time of those early days in 2020 and 2021, where they just weren't able to get the data that they needed to track resistant infections as much as they were previously. Globally, another group has done some work, particularly around antibiotic resistance globally during the COVID pandemic. I encourage you to check out this clinical infectious diseases supplement from 2023. There's lots of articles in that particular supplement. This editorial that I've cited here just talks about globally, there's a high baseline rate of antimicrobial resistance. And during the COVID-19 pandemic, we saw increased inappropriate antibiotic use as well as resistance. At baseline, healthcare transmission of drug resistance organisms was widespread globally, just like it is here in the United States. But the COVID pandemic amplified the horizontal transmission that we saw in healthcare facilities. And so that supplement with all of its associated articles talks about different countries and different rates of resistance that occurred in different places. So I encourage you to check that out to get a nice perspective of what was happening outside of the United States during that time period. So we know that antibiotic resistance is a global health threat. We also know that we had our challenges associated with the COVID-19 pandemic. So what can we do to address antibiotic resistance? Both the World Health Organization and the Centers for Disease Control and Prevention really are encouraging taking a One Health approach. And what that means is that that One Health approach takes into account the impact of antibiotic use, not only on humans, but also in the agricultural and animal environments, as well as our environment. So taking that into perspective and realizing that how we use antibiotics in each of those settings impacts those other settings. So taking that lens of this One Health approach, we need to, number one, improve antimicrobial prescribing. We need to, number two, prevent the spread of infections. So working with our infection prevention and control colleagues to help prevent infection spread in our facilities and in our communities. Number three, we need to be aware of local resistance patterns. So really relying on our clinicians and our microbiology labs to help us have that data available to recognize when there might be a concerning resistance pattern developing. And then number four, preventing infections, which can be done using vaccines, as well as, again, collaborating with our infection prevention and control colleagues to prevent the spread of those infections in healthcare facilities. So one of those key components, or the number one item on that list, was improving antibiotic use. And we can do that by really trying to optimize antimicrobial use. And this is where antimicrobial stewardship has its role. So antimicrobial stewardship can help improve antibiotic use by providing patients with the right antibiotic at the right dose for the right duration of therapy, and especially taking into consideration the right diagnosis. So making sure that all of those rights are in place, and that will help improve correct antibiotic use. And at the same time, that will decrease unnecessary antibiotic use and hopefully any adverse effects that might come from antibiotic use, including antibiotic resistance, as well as Clostridium difficile. The CDC really suggests the following strategies for using antimicrobial stewardship as a mechanism for addressing the antimicrobial resistance crisis that we're facing. They suggest the following of treatment guidelines. Evidence-based treatment guidelines to manage infections is a good tool that we can all be using in our stewardship programs to promote appropriate use. Secondly, acting promptly if sepsis is suspected. So antimicrobial stewardship is as much about decreasing inappropriate antibiotic use as it is about increasing appropriate antibiotic use. So those patients who are septic need rapid, appropriate antibiotics. And so making sure we're working together to emphasize that. I also alluded a little bit earlier that making sure the diagnosis is correct is one of those rights. So the right diagnosis. So using those diagnostic testing guidelines to help guide our therapy, making sure that we're collecting cultures when appropriate and not collecting them when they are not necessary. And then lastly, applying core elements based on treatment setting. And we'll get into a little bit more of that as we walk our way through the subsequent sections of the presentation. So that was just a brief overview of antibiotic use and antibiotic resistance and kind of what's this global situation that we're looking at. I would next like to step into an overview of what's new in antimicrobial stewardship. This is where I'll go over some new guidelines, some regulatory updates, and some other news in antimicrobial stewardship. I know you all are busy and may not have the time and or other resources to stay current with what's going on in antimicrobial stewardship. So I would like to take the opportunity to highlight some of the things that have been released over the course of the last year or so that might be helpful for you as you're thinking about what you can do in your stewardship program to address antimicrobial resistance. So the CDC every year releases antibiotic use data. A lot of times this comes out near the time of US Antibiotic Awareness Week. And the 2023 update is up on their website for everyone to look at and to take some key pointers from. When I looked at this update this year, I found a couple of things that were interesting. The CDC is really focused on looking at data around antibiotic use in antimicrobial stewardship. And so some of the highlights of the studies that they have done out of the CDC is first, they reviewed the literature looking for studies to characterize antibiotic prescribing health inequities. And what they found when they did this evaluation was that there is a variable rate of appropriate antibiotic use depending on patient and clinician factors. And so this is one of the priorities from their perspective moving forward for antimicrobial stewardship over the course of the next several years, is to really further look into those inequities and what drives those inequities and what can be done to address those inequities. So I encourage you to take a look at that paper to see more details about the information that they found when they reviewed those studies. Related, they looked at regional differences in antibiotic prescribing for respiratory tract infections. And what they found was that patients in the southern United States were more likely to receive inappropriate antibiotics. And so this, again, is another opportunity to look at antibiotic prescribing from a more regional level and to see how your state or your area of the country, if you're United States based, how antibiotic prescribing trends look in your area. And you can use these tools and this information from this study to educate your clinicians about appropriate prescribing, especially for respiratory tract infections like they saw in this study. And then last key point that I thought was interesting from this antibiotic use update was that they looked at a study comparing prescribing between physicians and advanced practice clinicians, such as physician assistants and nurse practitioners. And what they found was that these advanced practice clinicians prescribe antibiotics more frequently, although there really wasn't a difference between appropriate antibiotic prescribing between physicians and advanced practice clinicians. But I think this does highlight, for those of us working in antimicrobial stewardship, the importance of including these advanced practice clinicians in both our educational efforts as well as members of our teams when we're thinking about moving forward with our antimicrobial stewardship interventions. From a world perspective, the World Health Organization has updated their AWARE classification. AWARE stands for Access, Watch, and Reserve, and it's a classification system that is used to help monitor antibiotic use, define targets of antibiotic use, and evaluate the effects of antimicrobial stewardship policies. These categories are updated every 2 years, and so that was just published recently. Those access antibiotics are the ones that should be used in general and are generally narrow spectrum and not very toxic. The watch agents are broader spectrum and should be used with caution. And the reserve agents are those that should be reserved for those special situations where there aren't any other options available. Coupled alongside of this, they also released an antibiotic book, the WHO Aware Antibiotic Book, that has guidelines for adults and children on using antibiotics broken down into this classification system. And so this is a nice tool, again, for the more global audience to consider looking at in terms of how to define those targets and the effects of stewardship policies. From a regulatory perspective, for those hospitals or critical access hospitals here in the United States that are accredited by the Joint Commission, new antibiotic stewardship requirements went into effect at the beginning of this year, so January 1st, 2023. This should not be news to anyone, but if someone's new in stewardship or new in your position of stewardship in the United States, you want to make sure that you look at these requirements and that you're adhering to them. From my perspective, some of the interesting things from this new requirements is, number one, that you have to demonstrate that you have financial resources for staffing and for the information technology needed to support your antimicrobial stewardship program. So I think for those of us who worked in stewardship for a long time, this was a great victory to have this written out as something that has to be in place for your stewardship program. I think most of us in the United States are already reporting our antibiotic use, but that is something that is required from the Joint Commission as well. And then these last 3 bullet points are more in that action area of antimicrobial stewardship. So the requirement to implement either pre-authorization, which is where you would require approval before an antibiotic can be used, or prospective review, which is where those antibiotics would be prescribed, and then you would do that prospective review and feedback. You have to implement one of those 2 key strategies in your stewardship program. You have to implement at least 2 evidence-based guidelines, and the Joint Commission gives you some suggestions on areas where you might consider implementing those guidelines, such as pneumonia or urinary tract infection. It's not limited to those areas, but they do give you a list of infections you might consider implementing guidelines for. And then lastly, you have to evaluate adherence to at least one of those guidelines. So you have to implement 2 guidelines and evaluate adherence to at least one of them. So if you haven't checked those out, or if you're new to stewardship at your facility, you want to make sure you review those Joint Commission requirements and that you're adhering to them since they are already in effect as of January 1st of this year. Another new item that came out this year in August was the CDC Hospital Sepsis Core Elements. These are modeled after the antibiotic stewardship core elements, so if you're familiar with those, this will look familiar to you. It's anticipated that the Centers for Medicare and Medicaid Services, or CMS, will be moving forward with a 30-day mortality measure related to the sepsis core elements. So that's something more from a quality perspective that may have to be adhered to as well. The key point here is, and how this relates to antimicrobial stewardship, is sepsis is an infectious state. And so there needs to be collaboration between antimicrobial stewardship teams and sepsis teams to make sure that our efforts and interventions are working together and moving both stewardship as well as sepsis quality forward. So just to show you what those core elements are, like I said, they're very similar to our core elements for antimicrobial stewardship that we're familiar with. They include hospital leadership commitment, accountability, multi-professional expertise, which is a little bit different from stewardship. So that's just taking in all of those experts in critical care, nursing, et cetera. That's where that antimicrobial stewardship team member might fit on this team. The sepsis team needs to take actions. They need to track those actions, report those actions, and provide education around sepsis. So again, work in concert with your sepsis team to make sure that the stewardship team and the sepsis team are both moving their respective interventions forward, but in concert with each other. And if you're not also aware, the CDC has core elements for other areas of antimicrobial stewardship: hospital antibiotic stewardship, outpatient antibiotic stewardship, stewardship for nursing homes, human stewardship programs in resource-limited settings, and antibiotic stewardship for health departments. And it's that bottom bullet for the health departments, which is the newest core element document that was released this year. So if you work with health departments, whether it's at the local, state, regional, or national level, you should check out that document. This provides guidance on what health departments can do to advance antimicrobial stewardship. Also coming soon is a new reporting requirement from the National Healthcare Safety Network, NHSN, around the antibiotic use and resistance module, or AUR. This is part of CMS's Promoting Interoperability Program surveillance measure, and requires all eligible hospitals and critical access hospitals to attest to active engagement with NHSN by submitting data or claiming an applicable exclusion if they're unable to submit that data. And this will become effective in calendar year 2024. So if you didn't already know that, hopefully you're already working on this. We knew this was going to be something coming forward, but there's more information at the website on the slide here, and some resources and tools available in the NHSN system to help guide you through that process. The American Society of Health System Pharmacists and the Society of Infectious Diseases Pharmacists collaborated this year to issue a joint statement on the role of the pharmacist in antimicrobial stewardship. Previously, both societies had their own individual statements, but working together, they have come up with a unified statement. And some of the key points out of this are that, number one, all pharmacists have a responsibility to promote antimicrobial stewardship and optimal antibiotic use. That's regardless of whether they're an infectious diseases pharmacist or a generalist. But those pharmacists with education, training, or expertise in infectious diseases and stewardship should be recognized as leaders, or ideally as co-leaders of antimicrobial stewardship programs. The statement goes on to outline leadership and pharmacist responsibilities. And I would let you know that this statement does challenge us as antimicrobial stewardship pharmacists to push the envelope and to reach for, the highest level of practice within our stewardship programs. And although this statement is based on United States practices, I think it can be applied globally to our colleagues across the world to take into account these leadership and pharmacist responsibilities in their stewardship programs. Related to antimicrobial resistance, in June of 2023, the Infectious Diseases Society of America updated their guidance document for antimicrobial resistance. This document is updated annually, and the current version is available at the link on the slide here, and also available in your references. This guidance talks about managing infections for the 6 pathogens I've listed on the right-hand side of this slide. And I'm not going to talk about clinical recommendations today, because that's outside of the scope of this presentation, but I wanted to call your attention to this document and how it is updated annually, because that's different than most of our guidelines that are published less often, frequently than that. So remember to check in with this guideline. It includes dosing information and duration of therapy information for these multi-drug resistant pathogens. From a laboratory perspective, we work closely with our laboratory colleagues, both the Clinical Laboratory Standards Institute here in the United States and the European Committee on Antimicrobial Susceptibility Testing in Europe have released updates to their breakpoints. So those are available for anyone who wants to look at them. The M100 from the CLSI is a freely available resource at the website I've listed below. And you can find the UCAST breakpoints on the website as well. If you're interested in more information about MICs and antimicrobial susceptibility testing, you can check out Sanford Guide Educational Resources to find a post that we wrote about MICs and susceptibility testing, and talks more about CLSI versus UCAST data. And then the last thing I want to talk about is a people-centered approach to antimicrobial resistance. This was published just last month by the World Health Organization and really focuses on removing barriers that people have to accessing appropriate antibiotic therapy. It's based on four pillars. Number one, preventing infection. Number two, access to essential health services. Number three, timely and accurate diagnosis. And then four, appropriate quality assurance, which provides guidelines and programs for antimicrobial stewardship programs. So I know that was a whirlwind of new information that has become available for antimicrobial stewardship programs, but hopefully you can take a nugget from that or go check out a link that I shared to get an idea for something that you can bring to your stewardship program. So the next thing I want to jump into is strategies for getting started with stewardship. I know that some of us are well-versed in antimicrobial stewardship. In 2021, the CDC found that over 95% of hospitals in the United States were adherent to all 7 core elements of antimicrobial stewardship. But there might be people on the call today who are, worldwide or perhaps working in a setting where they're just getting started with stewardship, whether that's an outpatient setting or a long-term care facility. And so I think these strategies will be helpful for those folks. And then for those people who are more experienced, we'll talk about some tips for expanding your stewardship program as we end the session today. So there are 7 key components to starting an antimicrobial stewardship program. These are similar to the 7 core elements that the CDC suggests for antimicrobial stewardship programs, but I did also include references from the CDC as well as Pulsini and colleagues who created a checklist for global antimicrobial stewardship programs. And across all 3 of these, you see similar themes, which are that you need leadership support, accountability, expertise on infection management, education and training, actions, monitoring, and reporting. And so we're going to take a dive into each of these sections separately. So in terms of leadership support, accountability, and expertise, you need to develop a team. In an ideal world, that would include the people listed on the left-hand side under the core team. So an infectious diseases physician, an infectious diseases pharmacist, other clinicians from your healthcare facility, a microbiologist, someone to help you from an information systems perspective, infection control and prevention colleagues, a hospital epidemiologist, and quality improvement. But we know that not everyone has access to these team members. And so for resource-limited settings, the goal would be to try to get buy-in from relevant stakeholders. So perhaps that's all the providers at your critical access hospital. But at a minimum, that should include a physician and a pharmacist, should include nurses, infection control colleagues. After you get those people involved, you can consider collaboration opportunities, whether that might be with your larger healthcare system, if it exists, or perhaps local, so in a city or a region, you could collaborate with those people who are knowledgeable about infectious diseases that are around you to develop your team. And in even more advanced practice model would be telemedicine. So eliciting the help of a telemedicine service to help you manage your antimicrobial stewardship team. If you're in a resource-limited setting, or if you don't have infectious diseases training, there is training available. This is not an all-inclusive list, but I did my best to include trainings that were free, along with trainings that require payment. And so I've listed 3 that are free. So the CDC has an antibiotic stewardship course that's newly updated. It includes 9 modules and is delivered online. The World Health Organization has an online program as well that's 15 modules and is available in multiple languages. Here at Sanford Guide, we have educational resources for antimicrobial stewardship. These are online. Right now, we have 3 documents. They're free. They're not as all-encompassing as these modules that you see from the CDC or the World Health Organization, but they're really good for new learners, for students, and for nurses who might be new to stewardship. And you can find these educational resources got posted in the chat for you. So if you're interested in clicking on those, you can see those there. Now, the 3 organizations that I chose to include here that have Courses that require payment are the Society of Infectious Diseases Pharmacists, Making a Difference in Infectious Diseases, which is MAD-ID, and the Infectious Diseases Society of America. They have a combination of both online and in-person modules. The ones from SIDP and MAD-ID require also submitting a project. But they do include discounts for groups, for trainees, and for low to middle income countries. So you might consider checking those out as options to gain the knowledge that you need to move forward with your stewardship program. Now, when you're thinking about education of the providers at your facility, so once you gain that knowledge, now you need to educate everyone else at your facility. How can you go about doing that? You can provide in-service presentations or grand round presentations to, number one, enhance awareness about antibiotic resistance and antimicrobial stewardship. I know in my previous position, when we started our program, we did a lot of this messaging around what is antimicrobial stewardship and why is this important and how does it impact you and your patients. So I think that's a good thing that you can do. You can also publicize the program, whether that's through email or blogs on your website or through newsletters. We know that one of the best ways to elicit change is one-on-one education or coaching. Oftentimes you'll see this referred to in the literature as handshake stewardship. So approaching your colleagues and talking to them about an individual patient case and the antimicrobial prescribing choices that were made for an individual patient is a great effective education tool. You can also include information about antibiotic stewardship in your onboarding. So when new providers come to your facility to start working there, or new students or new residents, you can include information about your antimicrobial stewardship program in that onboarding and training. And then sharing your guidelines is another great way to provide education, because within your guidelines contains the right drugs, the right doses, and hopefully the right durations of therapy. And by including those guidelines and sharing those guidelines, you're educating people about appropriate antibiotic use. If you're looking for more resources for education, the CDC has great resources. These are also available via the Sanford Guide. Via Sanford Guide for our mobile app, you can access these CDC resources for both healthcare professionals as well as for patients. The resources for patients also include some materials available in Spanish. So if you're looking for Spanish language resources, you can find those through that patient link. And at the global level, I already mentioned the World Health Organization Aware Antibiotic Book, but again, that would be a great resource for educating those providers who don't have that background in infectious diseases on appropriate antibiotic prescribing. So after you develop your team and you yourself have learned how you're going to implement antimicrobial stewardship and you've educated your providers, what is that initial action going to be? What are you going to target? What are you going to start with first? I would encourage you to think about starting small and start with something. You have to have some kind of intervention. Consider maybe 1 to 3 interventions and maybe focus on a specific area of your hospital or a specific unit. Maybe you know anecdotally that there's a problem with prescribing on this nursing unit. Let's focus on that nursing unit as your first place to intervene. Use clinical guidelines to help guide therapy. Make sure they're evidence-based, make sure they're developed in consideration of your local epidemiology and resistance. And if possible, include those stakeholders in that guideline development. If they're included in the process of developing those guidelines, they're going to be more likely to use them. You might consider identifying agents that have high use. And maybe you do that by looking at a cost analysis of antibiotics purchased for your facility. Or perhaps you just know from your pharmacists and prescribers what agents are highly used at your facility. I've listed some example interventions below. You might start simple by training users on how to find and use your guidelines. You might implement antibiotic rounds where your team rounds on that specific unit or floor and talks to each provider about their patients on antibiotics. Or you might implement antibiotic timeouts where you encourage each provider to stop and think about whether therapy needs to be continued. You might consider implementing an intravenous to oral conversion program. You might provide patient education, and you might consider enhancing or evaluating your antibiotic formulary. These are just some simple ideas. The sources cited here on the slide provide more details about interventions that you might try at your facility. I do want to highlight institution guidelines because this is such a key component. It's mentioned in the Antimicrobial Stewardship Guidelines from Infectious Diseases Society of America, and it's mentioned in our core elements. You can use national or even international evidence-based guidelines if you don't have local guidelines. The key is to get some kind of guideline going at your facility. You might consider targeting one of the infections listed here on the slide. These are common infections that we see in hospitalized patients, regardless of where in the world you live. And then the key, again, is to disseminate those guidelines and provide education around those guidelines and even evaluate whether people are adhering to those guidelines. We know that guidelines have an impact. They're going to increase appropriate use, decrease durations of therapy, but the most important thing is they're going to encourage changes in practice and improve accountability. And by doing all of these things, they're going to enhance the effectiveness of your other stewardship interventions and give you time to work on other interventions because you have these guidelines in place, people can follow them, and then you can work on your next intervention that you want to implement. The last piece of your program should be monitoring and reporting. This is probably the most time and resource intensive part of antimicrobial stewardship. So you can start simple, track process measures like number of charts reviewed or number of interventions accepted. Potentially identify a target that you want to reduce antibiotic use for and track that. So maybe you want to decrease third generation cephalosporin use by 5%. Identify that target and then track your progress. If you're here in the United States, you have to submit data to the NHSN AU option, again, beginning effective next year. But if you're globally, you can use a defined daily dose to track therapy. You can look at provider level reports. Sometimes at our smaller facilities where there are fewer providers, it's actually a little bit easier to look at provider level data. And you can also look at cost data. Although that's not the ultimate outcome of stewardship, you can look at antibiotic cost data to see if antibiotic costs are going down. So hopefully for those of you that are considering starting a program, that provided you with some tools and ideas for how to get started in your program. Once you've gotten started, or for those of you that are more veterans in stewardship, the next section, we're going to talk about optimizing your existing programs and enhancing those programs. As I mentioned, 95% of the hospitals in the United States are already incorporating those 7 core elements of antimicrobial stewardship into their programs. And so what can you do if you're in one of those facilities to really move your program to the next level? And I hope some of the ideas from the next section will give you that spark you need to get started at your facility. So the first step is going to be to identify your opportunities. This can be done in a lot of different ways. You can do a gap analysis. The CDC has a really nice tool that you can look at that allows you to do that gap analysis, comparing your program to those core elements, and if you're meeting each of those core elements. In the paper I talked about earlier that I've cited here with the link, there is a checklist for global hospital stewardship programs. So you can look to see if you're meeting those global checklist criteria. You can also review antibiotic use data. So all that data that you're collecting and monitoring, you can review that and look for trends and identify opportunities that way. You can review your resistant organism data as well and look for patterns and changes that might necessitate an intervention. So these are just some ideas on how you can identify those opportunities to take your program to the next level. I think this is a really fun area, which is growing your team. I've been to a lot of presentations over the course of the last year, and this is something that I found to be really interesting. So growing your team, not just including the same people who've been on your team since it started back, 5 to 7 years ago. Consider inviting clinicians from areas where you're having challenges. So if your medical ICU is a challenge to your stewardship program, invite the people that practice in that area to be a part of your team and have them work with you to overcome those challenges. Because again, if they're part of developing the guidelines and the interventions that you want to use, they'll be more likely to adhere to them and also to encourage their colleagues to do the same. Advanced practice providers. So I mentioned the CDC did that study looking at advanced practice providers, and we know from their work that advanced practice providers, such as nurse practitioners and physicians assistants, are high prescribers of antibiotics. And so we need them to be part of our team. We need to educate them and to include them on our team, again, getting them to buy into this antimicrobial stewardship process so that they appropriately use antibiotics. A third group to add to your team might be hospitalists or intensivists. If your facility uses these types of providers, they might be the vast majority of people prescribing antibiotics at your facility. And again, bringing them onto the team and getting them to work with you and to share your challenges back to their groups can be really helpful in getting your stewardship interventions to meet their goals. I would also encourage you to invite bedside nurses. They can do a lot around particularly intravenous to oral, as well as microbiology resulting. They're right there when the prescribers come by to visit their patients. So encouraging them and engaging them to be part of the team can be helpful. There's so much growing in the area of diagnostics, making sure that if you don't already have your microbiology colleagues on your team, to include those, but also to be considering these rapid diagnostics and diagnostic stewardship. Some facilities have a separate diagnostic stewardship team. If that's the case, make sure you're working together with them to incorporate diagnostic stewardship with your antibiotic stewardship principles. And then lastly, partner with your quality improvement colleagues if you haven't already. A lot of times, if you're working on initiatives that are already important to your hospital from a quality improvement perspective, that can help you get the buy-in that you need from your leadership and management to move your projects forward. Another thing you can do is look at these priorities for core elements that the CDC has recently added. This is done in large part because most programs, like I mentioned, are already adhering to those 7 core elements. And so these priorities on the right-hand side of the screen are areas that have good evidence to support their effectiveness in antimicrobial stewardship. And so you'll see down there when you look at reporting that you're adhering to reporting requirements, but you're taking an even deeper dive and looking at prescriber level reporting, unit level reporting, or service reports, at least annually to your providers. So consider that if that's not something you're already doing. And then, of course, monitoring adherence to that facility-specific treatment guideline, which again is a Joint Commission requirement if you're here in the United States. But I encourage you to look at this document and to look at these priorities to see if there is anything that you can do in this space for your stewardship program. For the next several slides, I'm going to use this paper that was published in Open Forum Infectious Diseases by several pharmacy colleagues regarding improving efficiency in antimicrobial stewardship programs. This paper really has a lot of great ideas, and I would encourage you to take a look at it if you're at this place with your stewardship program and you're wanting to take that next step, or if you're at the place where I think a lot of us are, where we feel like we're not very efficient in our daily activities. This paper provides a lot of great resources. But what it does is it recognizes that these core element priorities are really resource intensive. Performing prospective audit and feedback is really time intensive, especially if you don't have a lot of information technology resources to help you with that chart review and identification of patients who most need your intervention. So they propose 4 steps to optimize your workflow. The first is identifying your resources. So what personnel, technology, and time do you have available for your stewardship program? And then once you know that, prioritize your initiatives, focusing on things that are impactful, feasible, actionable, and measurable. And then develop your alerts, keeping in mind those same 4 points as before, making sure they're impactful and feasible, et cetera. And then prioritize your daily tasks surrounding this new workflow. I will also mention that they did recommend as well that these when you're working on developing these initiatives, again, keeping in mind what's important to your hospital or your facility and aligning your initiatives with those quality improvement or other things that are being done at your facility can be really helpful, again, in getting buy-in. So taking a look at prospective audit and feedback, you can use the data that you're collecting already to identify areas with high use and focus your efforts in those areas. So I mentioned that for those people who are starting new programs, it's the same idea, the same concept. Really try to hone in on one area and take care of an issue in one area before you move on to the next. Some other things that you can do in the area of prospective audit and feedback is review certain agents at 24 hours if you have the availability of rapid diagnostics results and the technology to get those results to you in a timely fashion. You can also identify syndromes where you do your review at the time of initial order. So for urinary tract infection, for example, every time someone is prescribed an antibiotic for a urinary tract infection, I'm going to do the review before I release that order to the patient. And that way we get the antibiotics right from the beginning. And then lastly, use a tiered approach based on your resources. Some tasks need to be conducted every day. Every day you need to look at these agents that are at the 24-hour mark. So maybe that's your vancomycin for bloodstream infections. Every day you need to look at that. But there are other interventions that maybe you do twice a week or maybe just once a week. And so really use your resources to focus on those highest win areas and leave those things that maybe aren't as effective to be just done once a week. They do have a really nice tool in this paper to help you identify if that intervention that you're wanting to implement is going to be high yield based on your resources and tools that you have available to you. The next thing I would challenge you to do with your stewardship program is to consider expanding to new settings. So perhaps you already have a robust antimicrobial stewardship program. Think about where else you can take this program and expand it to new settings. If you're just getting started in stewardship, maybe you've been working for 1 or 2 years and you implemented one intervention like I suggested, maybe now is time to take the step towards implementing prior authorization and feedback or formulary restrictions. So think about where you are with your program and which one of these applies to you. You might consider working on delabeling antibiotic allergies. There's been a ton in the literature about particularly pharmacists working to improve antibiotic allergy documentation, which has subsequently led to more narrow spectrum antibiotic use. And you can focus this effort on your surgical prophylaxis antibiotics. And you can have some really nice victories in decreasing that broader spectrum antibiotic use by getting people's allergies correctly incorporated into your electronic medical record. Perhaps it's time to expand even bigger and go out to a new setting. So maybe you want to expand out to a nursing home or a long-term care facility that's part of your healthcare system. I think outpatient antimicrobial stewardship is a hot topic right now, including urgent care and telemedicine. So think about what you can do in outpatient setting with the resources that you have already developed for your inpatient program. And then if you have a small or critical access hospital in your healthcare system, expanding out to those settings and making sure that they are moving forward with stewardship at the same pace that you are at your healthcare facility, it can be helpful too. The next thing that experienced programs might consider is leveraging antibiograms. So antibiograms are not without limitations. In fact, there was a recent paper calling out some of the limitations about antibiograms, and you can find that cited at the source at the bottom of the screen here. Sanford Guide, we have all about antibiograms page that you can take a look at and includes a citation to that paper. But stewardship programs can really use antibiograms. Number one, you can use them to help inform empiric therapy recommendations for an individual patient. And you can teach your providers how to use your antibiograms to make those decisions. You can also use them more globally as a stewardship program to help develop treatment guidelines or algorithms for your facility. So again, this is a more advanced level of developing treatment guidelines by incorporating that facility level epidemiology data and resistance data into your guidelines. You can also use them to monitor trends over time, and you can compare them from year to year and create graphs and tools to share with your providers. Maybe you want to track Pseudomonas resistance to carbapenems over time. You can use your antibiograms to do that and to show these graphs. You can use them as educational tools, again, as I mentioned, one-on-one or in a bigger audience to teach people how to approach empiric antibiotic prescribing. And one thing that you could also consider is expanding your antibiogram capabilities. You can do this by offering stratified antibiograms, which means offering unit level or maybe patient population level antibiograms. You can also consider in that same realm like a urine antibiogram, a blood antibiogram, a trauma antibiogram, whatever different types of patients that you might have or different types of infections you might have, you can stratify your antibiogram to provide better guidance to your providers when it's more narrowed down like that. You can also consider combination antibiograms, which would be where you take a look at different combinations of antibiotics and what's the expected rate of susceptibility when you combine two antibiotics. And then there is this idea of escalation antibiograms that we won't get into today, but these are all different concepts or ideas that you can use with your antibiograms, from very basic to using them to recommend empiric therapy to the most advanced, which is developing these more elaborate antibiograms. I encourage you to take a look at our resource that we have available to learn more about antibiograms, share it with your students, your residents, so they can learn more about how to use an antibiogram making therapy decisions. One of the other things that you can do is distribute your guidelines. From the very basic paper or pocket card all the way up to electronic. That can be through your intranet or electronic health record. You can distribute them through a custom mobile application. Our product, Sanford Guide with Stewardship Assist, is one of many available options that you can use, but really gets those guidelines into the hands of your prescribers when they're making decisions at the bedside. No matter what you do, you need to provide access to those guidelines, and you need to educate people that they exist, because if they don't know they exist, they're not going to use them. So whichever method you're going to use, and maybe it's multi-pronged, you're going to give them a paper, you're going to put it on your intranet, and you're also going to have a mobile application. You need to make sure people are aware that they have access and the ability to use those guidelines in their patient care. There's some other tools here that you can use. There's toolkits for acute care, long-term care, and ambulatory care through the Agency for Healthcare Research and Quality. The British Society for Antimicrobial Chemotherapy has some antimicrobial stewardship principles that you can take a look at. Lots of our local, regional, and national health departments had tools for antimicrobial stewardship. And then you can also consider electronic health record and clinical decision support tools to enhance your program. So I hope over the course of our time together, I've encouraged you to understand that stewardship is one strategy to combat resistance. I've made you aware of some new guidelines and regulatory standards and the importance of keeping up with that literature to make sure you know what you need to do next with your program. I've given you some strategies for getting started with stewardship, regardless of the resources that you have available to you. And I hope I've given you some options for expanding the reach of your stewardship program. So at this time, I will stop and we will take questions from the audience. Let's see. Okay. So the first question that we have in our chat is, I've heard Sanford was working on IB2PO guidance to help in antimicrobial stewardship efforts. Is there any update on the timeline and when these types of materials will be coming? And so, yes, that is something that we're working on with our editorial board. Hopefully that will be coming in the beginning of the new year, and we'll give some opportunities for your programs to have a tool to use to encourage your providers to make that change to PO. Have you seen the increased use of telemedicine correlated with increased antibiotic prescribing? That's a good question. I do know that there is some evidence surrounding urgent care visits and increased prescribing. I'm not familiar off of the top of my head about telemedicine specifically, so that'd be something I'd have to look into a little bit more. But I could see that that could be something that could be correlated, but again, I don't have a good answer on that. This is a good one. How do you deal with long-standing established practices by experienced surgeons? And this is certainly one that those of us that have been in stewardship for a long time know well. And I think this goes back to growing your team, and that is you invite those people to be part of your team. I know at my previous facility, we did that, and they didn't often show up, but getting them to be on your team can help you a lot. You also need to get their physician assistants and nurse practitioners to be part of the team, because oftentimes those are the people who are doing the prescribing for pre and post-op antibiotics. And when you call them or you make your intervention with them, they often tell you that's what the surgeon told me. And so we need to have that line of communication between that surgeon and their advanced practice clinicians to make sure everybody's on board with these stewardship recommendations. I know that's a hard one, and I know I'm making it sound like it's really easy, and I know it's not, but you've got to get that buy-in from them, have them work with you to develop the guidelines for their particular surgical area and get them to be a part of your team. How can we optimize antifungal use empirically? Are there any guide material scores to help? Appropriate antifungal use, you can use the same principles that we talk about with antimicrobial stewardship. Oftentimes these fungal infections, at least here in the United States, aren't always the first thing we think about. But again, the same principles, the right drug, the right dose, and the right duration of therapy. Within Sanford Guide, we do have information about fungal infections and a fungal spectra of activity that can help you to some degree. But I think that's something that's still growing and developing globally is antifungal stewardship. Let's see. How can we judiciously use antibiotics in underdeveloped countries where cultures are not always available? This is a good question. And I think this is where you can take those national guidelines or even international guidelines based on what we know the typical epidemiology for these infections is and the recommended empiric agents for those infections. And you can use that to help you with appropriate prescribing by incorporating those guidelines into your electronic health record or just having them on paper order sets, whatever is available to you. But using those national guidelines or international guidelines to help you when you don't have local data is a good starting place. And it looks like we are getting close to 3 o'clock. I have 3 o'clock here on my time here, Central Time. So we've reached our hour. I want to thank everyone so much for joining us today. I hope this was helpful, and I hope no matter where you are in your stewardship journey, you can take something back to your facility to incorporate maybe just one nugget that I shared with you today. If you have any questions, we have our stewardship@sanfordguide.com email address up here on the screen, and we look forward to you joining us at a future presentation. Thank you all.